I want to thank everybody for joining us. I'm your host, Dr. Jeff Brown of the Merge Medical Podcast. I'm joined today by my co-host, Dr. Jeff Cole, and the founder of WellPro, Dr. David Lefkowitz. WellPro is an AI-native, HIPAA-compliant SaaS platform developed for wellness practices and clinics. It leverages advanced AI and analytics to improve provider productivity, drive revenue growth, and enhance patient outcomes by offering decision support, personalized treatment plans, and insightful analysis of patient biomarkers. And before we really get going, I want to just say we messed up and we've talked with David for over an hour. We didn't press the record button. And we've had such an amazing conversation that we wanted this to continue. When we realized we hadn't pressed record, I said, that's fine, because you guys, this is one of the best podcasts we've ever done. I could talk, at least for me personally, I could talk with David for hours about what we're about to discuss. David, I read straight from the website, but that's the last time I'm just going to read something. Tell us about WellPro.
Well, first of all, it's my pleasure to keep talking about this. So I'm happy that it was recorded the first time, so we have an opportunity to keep this going for a while longer. But your description is a mouthful, right? And that's the website. Really is a landing page. We set that up over a year ago, and we haven't really touched it. But essentially, what we're building is an AI native EHR, and I'll talk a little bit more about that. But we call it IHR, Intelligent Health Records. And so the idea is, how do we use emerging technology to really augment and optimize the clinical workflow?
So there was one slide in your deck that talked about the progression of EHRs and just documentation through the years, going back to the 70s and the focus on precision medicine and now where we are. Can you talk just a little bit about that progression and kind of where you're kind of jumping in here?
Yeah, we're very exciting times because we really have the convergence of two major trends, major shifts. One of them, of course, is, as I was describing earlier, AI is, I don't love using that term because it's overly used and overly hyped. In fact, AI has been around since the 50s. An if-then statement is AI, right? But there's some transformative capabilities from it, that large language models, the ability to take unstructured data and convert it into structured output, the ability to use natural language to communicate with your data. These are pretty significant. So that's one major trend, and we're in the very nascent early stages of it. But there's another emerging trend in addition to this one, and this is just a double whammy. It just makes it so much more incredible. It's a once-in-a-lifetime opportunity, which we all feel that healthcare is changing, right? I mean, it's just in the air. We all feel it. And there's a significant trend towards personalized medicine, and I'll describe that because that's sort of a term that we're using to try to categorize this. And it's a little bit different from precision medicine that focuses on genetics and targeting individuals' care based on their genetic composition. But personalized medicine is, we look at it as a holistic approach to health, right? And so preventative. And some of the trailblazers that are driving this type of medicine are functional medicine providers, integrative medicine providers, longevity clinics that are looking at a whole enormous amount of data points beyond what traditional allopaths look at to be able to identify root causes and how to best serve and deliver care to their patients and their members.
David, I want to go through this in really a lot of detail. Your system, you can take 400 pages of my life history, x-rays, lab results, vital signs, notes, dump it in there, and then it spits out actionable outcomes. Is that correct?
Well, yes, that's the foundation of what we're doing, and this is how it's very different from what I think other applications are doing. Most systems are doing what we call point solutions or co-pilots. Where we're really coming in is we're building this system from the ground up as an AI first. And so at the very core of it is the ability to take all the patient's data. Some new patients may have a few documents. Some may have hundreds of documents, depending on the complexity, the age. And how do you bring all this together and contextualize it and connect all the dots? That's one of the key components. And once you have all this data contextualized, and how do you use that throughout downstream and upstream throughout the whole clinical workflow, right? And so when you couple that with new data, like wearables and new diagnostic tests, how do you incorporate that into the whole context of a patient? And so that's at the foundation of what we're building.
Is it sophisticated, or would it be fair to say that your system is listening to the practitioner and the patient, have the conversation, and it's like another really smart person in the room that could maybe send a prescription or book a future appointment or to see another consultant, etc.?
Well, that's a part of it. So let's think of it more not from a technology perspective or even a solution perspective, but let's think of a typical clinical workflow. So you've got a pre-visit, right? So before you see a new patient or existing patient, you want to get refamiliar with their data, or familiar if it's a new patient, and get a sense for their background, what's happened across their life, what are their symptoms, what are their issues, what their family history is. Once you get a sense of that and you go see the patient, whether it's an in-person encounter or virtual, you're going to have to listen, take notes, right? Generate those notes, and then you're going to have to figure out what level of care, what treatment plan to put in place, and then follow up on a bunch of other things, like come back in 6 months for your additional blood tests, take these medications, take these supplements, change your diet, incorporate XYZ into your lifestyle. And so that whole workflow is enhanced significantly by having the contextual information about a patient. So if you think about that first piece of really being able to load and for us to process and contextualize all that patient data, in the pre-visit, then we can provide summaries. So you don't have to go through all that information. And one of our tools is projecting out the life events timeline, where we organize all the data in terms of an overall timeline, even a timeline across visits if you want to see the clinical timeline. And so it just organizes all this data in a way that makes it much easier to process, to internalize. And then as the encounter starts, we have an ambient component, which you guys have probably heard of because everybody and their mother is building an AI scribe, right? To hear these encounters. That's what I would call a point solution. And so we have the ability to capture that conversation and incorporate it into the rest of the context of the patient's story, and generate clinical notes from it, identify follow-up action items that need to go, and that goes into the post-visit, right? Also generate a treatment plan based on all of that information. And so what we're trying to do is not to provide specific direction or specific answers, but provide enough context, enough information so that the provider can make the best decision. So if there's a condition that you're not familiar with, right, it would be a significant undertaking. And I think that this is where a lot of situations happen where the provider needs to go and consult with other providers. I've got this complicated case. I don't know what it is. And so imagine just being able to have all the possibilities, and you can go one by one as a checklist and try to figure them out, right? It's a significant enhancer. And so the part that we're starting to work, because this is a platform we're building, is on the clinical workflow side. It's more the augmentation, providing information, almost like surfacing the right insights in the right place at the right time for the provider.
For the right recommendations, or even counseling for the patient that you just need to stop doing this, or you need to just to do items for the patient, right?
Yeah, absolutely.
Because I feel like you're playing at a much higher level. You mentioned earlier healthcare is changing, and I think healthcare really must and has to change, because the insurance industry is letting us down, the food industry is letting us down. And I think it makes sense that, I think your go-to-market strategy is with the wellness clinics, because there are a lot of people that they understand that, and they're looking for ways to make sure their health is optimized, because they're not getting it in the traditional system.
Of course, that's in the minority because it's cash pay out of pocket, so it's not democratized yet. But I think it's a good way of seeing what the future may look like or will likely look at. That's part of our thesis, that healthcare delivery will become personalized and holistic and preventative and data driven. And so with the advent of all these advanced diagnostics and multi-omics, and we are going in that direction. But if you think of some of the systemic barriers that you just described, there's a few others too. And, my wife is an internist. She's been an internist for many years. We've been married for 20 plus years. And so that's been my world, entrepreneurs and doctors. I will say that if you went to medical school 20 years ago, the amount of information and new insights and new studies, evidence-based, that have occurred, there's thousands of new evidence-based studies that happen every day. How do you keep up with all that? Number one. Number two is, and again, one can be critical of everything, right? But when you look at these legacy systems, including medicine as, let's call it one of them, with all the merits it has, how do you update the curriculum in an effective and efficient way? When I forget the name of the board, I think there's 18 board members that really regulate the curriculum of medical school. Nutrition is still not a core component, even though now we know for sure it's lifestyle and nutrition is a key part of preventing disease, right? And so genomics, most internal medicine practitioners, which are the quarterbacks of medicine, didn't learn anything about genomics. They still don't. What time are they going to have to go out and learn all this stuff? They barely have time for their families. I mean, the famous pajama time, right? I mean, so how are they able to absorb and incorporate all this new knowledge that maybe is 15, 20 years old? They've gone to a few courses and here and there, but there's just so much new insights and so much new information that does not make it to the providers. And by the way, at the end, physicians and mid-levels, nurses, when they go to medical school, they go to school, they're studying to pass the tests, right? And the testing is still done very much based on a 20-year-old curriculums, meaning that has not been updated. So we have another systemic barrier there. And I think one of the things AI can accomplish is now you have this whole knowledge base that can be shared and integrated into the provider's workflow.
I think things have definitely shifted from you've got to know all of this to where you got to know where to look. Because, when I started, we had a PDR, it was probably 3 or 4 inches thick, and we were expected to know every drug in that book, mechanism of action, side effects, at least a large percentage of them. That it's impossible, but we've got these peripheral brains, called phones. It's got all the world's knowledge in there. As you're saying, that knowledge is increasing so much, you may not even know where to look. So we're going to depend on AI, for lack of a better word, right, to summarize and help us sift through what's relevant to our current situation, right?
Well, and one way of looking at it is, for lack of a better term, if we don't think of AI as a whole, but these language models, what they're doing is they're constantly training on the latest and greatest. So they're very, very smart. They know a lot of things and they keep up with time. And so the idea is not that the AI is going to tell you what to do, but it may give you a list of all the things to consider and think about that you may have not thought of already, that you can further research. And by the way, you'll have a chat. So if you have follow-up questions, you can communicate with with your model. And so there's a lot that goes behind it to make sure that it's safe, it's compliant, there's guardrails around it too. But that's the idea, really. And one of the interesting things about medicine, that if you think about it, there's no other professional career that is like this. If you're more experienced, you don't get paid more. So in what other professional career, if you've been doing this for 15, 20 years, your rate and how much you're paid is exactly the same as if you just came out of school. Experience is not that doesn't happen in any other career, right? And so, but that's from a remuneration perspective. But let's talk about standards of care. You can have a physician or a mid-level that graduated from some of the best medical schools, that has been around for 25 years, it has the latest and greatest, and somebody that is very inexperienced. And the standards of care are so different between those. So I think one of the things that these models help is leveling the playing field. And from the perspective of being able to standardize level care for patients as well. So you need the ability to implement a workflow, a user experience that allows providers to be able to leverage all this information, right? And so that's where we're building, is really the user experience around it. We're not working on the models themselves. There's plenty of folks working on that problem. And on the infrastructure side, we're bringing the applied AI, the vertical piece, in place so that folks can leverage this technology. And one of the reasons that we're doing this from the ground up, and I think it's a very important piece, because there is sort of, most of the players today, or a lot of them, are building point solutions, which just are incremental value add on a specific feature or function. I think a lot of folks are coming to realization now that that's becoming commoditized, like AI scribes. So they need to have broader coverage of the workflow. Then you have all these AI co-pilots sit on top of legacy systems. And I think from a short to midterm, that makes a lot of sense. It's the quickest path to revenue, to growth, because legacy is the incumbent, right? A lot of it across healthcare systems. The very large EHR players are well established. Healthcare systems have spent millions in years to implement these things. They're not just going to go away over time. We're looking at a more longer term outlook. And so if you distill it down to the essence of one of the reasons we want to build from the ground up, is not only can we make these systems significantly more efficient, but one of the downsides of EHR systems, what is, the patient story got lost. So back in the day, and this is through a lot of conversations, so please, Jeff, correct me if I'm if I'm wrong or you have anything else to add, but the doc or the provider would write the story. This person came in, they had this. A few weeks ago, they were laid off. They're very stressed. What EHR forced was to convert all that into fields, into structured data. So a lot of the context-rich stuff, the patient story, is lost. Now it's been distilled down to fields and records. And so it's significantly harder to really get the full richness of the patient story from fields.
100%.
And that's not going to change because you have AI layered on top of legacy, because you're still optimizing the old. You're still optimizing this old infrastructure where it's lost the richness of the data. It's lost the patient story. And so the ability to build it from the ground up and leverage that. And so that's why a key part of this is being able to bring in and ingest all this data, develop these timelines, and contextually speak about the patient, not only in one dimension, but longitudinally. And I think that's one of the things that we heard over and over, I heard over and over, is we need that longitudinal data. We need that context. We need the patient story to really make some effective decisions and really help.
I mean, you're really touching on a point here, I think, that would help more in like a traditional insurance type patient setting. But a lot of doctors quit when the EMR system rolled out. And it's because of the fields you're calling that are just garbage, that aren't meaningful to patient care. And so for me as an anesthesiologist, I'm creating an assessment, a plan. I'm going through the data. I'm going through the chart, if you will. It's really not possible for me to do the job that I really would like to do each day because of all the garbage that's and it's no one's fault. It's the way it is, the way those systems are set up. You've got field upon field upon field, and the system isn't sophisticated enough to understand context and put that into a usable summary. Patient XYZ had this echocardiogram. This is their functional capacity in terms of climbing stairs, etc. So I really see the value in where this is headed. I wanted to ask a little bit more about like the technical side of what this does, because I really thought you were going to come in here and say you had laid this on top of Chat GPT or whatever system, but you're building this from the ground up. And what kind of compute are you having to use to do this? If this is your own proprietary system, right?
But you're using APIs to talk to language models, right?
Yeah. So our focus is the UI, UX, the experience, the workflow. I mean, really, we're building the workflows to leverage all this infrastructure. But that is a good point. And let me take it a couple steps back, because I think I mentioned it in the first hour that was not recorded, but I'll bring it up now. Is I didn't have any healthcare experience. My background is in supply chain software, in real estate development, and financial services, and e-commerce, on-demand manufacturing, some other sectors where technology has always been the common denominator. But I came into this really naive, and I was able to look at things from a first principles perspective. And that's perhaps why we're doing what we're doing, is because I was so clueless about how significantly challenging this was going to be. And so I built a team of experts. We've got a couple of very seasoned health tech executives that have spent years leading product and customer experience and user experience at large companies like Veradigm and Allscripts and a few others. They built genomic platforms. They've done a lot of different things. They know how to manage really large teams. And so we're scaling the team very quickly, but we put a lot of thought behind this on planning the growth of this platform. Now we're up to 16 developers. We're probably going to be doubling that in the next few months, and we're continuing to build out capabilities. Our goal is to deliver a beta in midsummer and have a first commercial release by the end of the year. But to the initial point, so from a technical perspective, there's a lot that goes to this, even if we're not the ones building the proprietary models. And by the way, there's no need for that. When I was first starting to try to figure out how to assemble a team, I wanted somebody that had incredible expertise in AI, somebody that had expertise building a B2B SaaS platform, somebody that had clinical expertise, and somebody that had a healthcare administration expertise. You need all that. That's impossible. Even 3 out of 4 is almost impossible. And so you really need to build the right mix. And when you see a lot of these technology companies that are bringing in these point solutions, they're all a bunch of young Y Combinator, young technologists, which there's nothing wrong with that. Great to them. And they're leveraging, but I don't think they have the seasoned teams, the experienced teams to build something in this space that is so complicated. I mean, just when you look at compliance and HIPAA and every little step to do it right, it is a business in its own. I mean, you need a team in its own just to manage that. And so what I'm trying to say is the barriers to entry are significant. You got to be a masochist to want to go into this route. And when I say this route, I'm not talking about a co-pilot. I'm not talking about that just lays on top of an existing system, but building out from scratch a new system that has to have all these components. And Jeff Cole, you understand this perfectly because you mentioned it too. That was a showstopper for you. We're already looking at incorporating these components so that we are certified, and we can be certified next year. But we're not having to do all the groundwork ourselves for that piece, right? We're inheriting. So there's a lot of components to this, and so bringing the right teams. But how many multi-billion-dollar EHR companies are there? 10 or 15 at least, right? So there is plenty of space for many more players to come in, So anyway, this is so much fun. I'm so excited. I look at the world as pre-2022. Pre-December 2022 and post-December 2022. And what happened in December 22 is when we all got exposed to magic, right? When ChatGPT came out. Where I remember those early days, it was like, wow, it'll create a song for me, right? I'll give it a theme and it'll make it rhyme, and this is unbelievable. But that's when language models were introduced to us, the ability to talk to the machine with natural language and get really eloquent responses. And so almost anything that I see that was started to build before that is sort of built on legacy. But even if you look at some of the AI companies that were built before that, they had to go in and build their own models, their own LLMs. And as we know, that takes a lot of resource, a lot of money, a lot of funding. And the advantage, and what we're continuing to see, is models are getting smarter and better. And there's already plenty of large players out there putting billions into this, including Google Cloud, which is a platform we use. Their Med Gemini language model is unbelievable. And so they're just getting better. They're going to continue to get better. And there's dozens of them. And there's open source models that are coming out. There's closed sources. So we have the benefit that we have access to a lot of different models that we can constantly test and use the best one for the use case. And that's where it gets complicated, because every single use case that I've described, whether it's generating content, summarizing, developing treatment plans, the chat, all those require the use case can merit different models in the way the orchestration of those models happen. And we can define that for each of these use cases. Each agent is also going to potentially require a different model. So we're leveraging the infrastructure that's already being built, and it's evolving very quickly and getting better. What we're doing is developing the interface, the experience, so that providers can get the insights that they need when they need it, the right place at the right time. And so there's a lot of things happening behind the scenes, talking to a lot of different systems and a lot of different models that we use as input.
I mean, I don't know if it's exactly the same. It's almost like Windows put that layer on top of DOS to give people the ability to interact with their computer. You're kind of putting that user interface on top of multiple AIs with APIs and interfaces.
Well, that's one way of looking at it, for sure. And I think that's a very sensible way of looking at it, is that we're providing access to a lot of different models, and we're making sure that we're generating the most quality, safe output. But there's another component to this, and this is not just orchestrating different models and creating that layer. Building from the ground up also means creating a data infrastructure. And so that's probably one of the biggest challenges with legacy systems. Our data architecture includes SQL, GraphQL, vector databases, which is where we parse and all the data from unstructured documents, and also FHIR data standards. Just the data architecture piece is really enables us to have unstructured, structured data pull if we need to be interoperable with another system, because that's part of where we are today, right? We're going to have to interact with other systems, going to a specialist, and you want to share that data. We can convert that data into FHIR standards so it can be easily shared. And there's a lot more to this, but ultimately, the direction we're going is being able to develop what we call personal health language models, which is a model that trains on each individual over time. It's portable, so you want to go to and see another provider, you give them access. They can query any information they want about you.
And David, let me pause. And in that setting, the patient would be your client, not the provider, or?
Okay, very interesting observation. Right now, this is a B2B platform. It's for the provider. We're going to have a B2B2C component, or a B2C component, which is a portal, which is not only going to be the traditional portal, but one that's going to drive engagement. And I'll give you a few examples. But eventually, we see this as also the stickiness where the individual patient can continue using WellPro, even if they go from one provider to the other. It doesn't mean that the other provider may not be using another EHR, but it's an it's almost like bringing the portability of the data. And the best example I can provide is this. So one of my co-founders, who's the head of user experience, he was a Navy brat, I guess you would say. I'm from Venezuela originally, South America, so Spanish is my first language. So I think you call it Navy brat, right? When your parents are moving all over the world, and so back in those days, in the 70s and 80s, his dad needed to carry around with him his own patient records, because when they were moved to Germany, stationed in Germany, he would have to bring his own records to the doctor in Germany. The doctor would do his notes, hand them the note, and he would have to compile and aggregate and keep his own notes, right? And so let's think forward. It's the same idea, but in a digital world, where in an AI world, where you want to own your healthcare journey. You want to own the data, right? You don't want to have to depend on this provider or that provider. You want to be able to have everything consolidated. You want to be able to share it with whoever you want, whenever you want, right? And you want to be able to have access to your own insights. And so that's part of the idea here, that even if you're on WellPro as a patient, or, a lot of these personalized medicine practices call them clients because they're not necessarily sick. Many of them are just trying to optimize their health, not necessarily addressing. They want to prevent chronic disease and just manage it or address it. And so that's a component that we're thinking a lot about also in the near future, is making it portable for the patient to own their data, own their healthcare journey, and share it as they will.
Boy, Jeff, we've talked about that a lot, haven't we?
Yeah, in fact, you bring it up. So, you say patients will own their data. Will you have uses for that data from a monetization standpoint? Because a lot of the big EHR companies kind of get a bad rap on that, where a lot of clinics just literally don't have access to their data. They find out that you don't own your data.
Well, I think we all agree there's a lot of barriers to that, right? It's not easy. I mean, the data is not all digital. Some of it is hard copies, and where is it, and who has it? And from a monetization perspective, there's plenty of ways to monetize on that. I mean, and there's so many other areas where in parallel industries that can benefit from having accesses. And I'll just mention a couple, just to give you an instance. I mean, just on the clinical trial side, being able to recognize and identify which patients are potential candidate for trials. There's software out there, and there's point solutions and AI solutions that are coming out with this. But again, it's significantly challenging because it's a point solution and there's limited data, right? And a lot of that data is private, and how do you access it? And so there's a lot of complications with that. But I think we're going to get to a point eventually where, again, you own your own data. You want to provide access to potential clinical trials because you as a patient can monetize on that to a certain degree. Then you have the ability to do that, and then you would allow the provider to monetize on that data, or the platform to monetize on that data. Today, the end patient doesn't get upside from having their data participate in this ecosystem. And so that's one piece, but that's not our core business today. But I think what you're pointing out is being able to have all this data consolidated, aggregated, will allow us eventually to do many more things and create many more sources of monetization in the future. And absolutely, but I'll give you another example. So let's say epigenetics. I mean, just to give an example of something that, a lot of people are looking at biological age, and they're looking at gene expression, right? It's amazing how now when you look at genetics, before we thought if you have propensity for cancer in your genes, you're screwed. I mean, there's a pretty good chance. Today, they're saying genetics only play about a 20% role in this. What really plays a role is gene expression, whether the gene is turned on or off, depending on your lifestyle, the environment you live in, right? And so that's where epigenetics, as you guys know, come in play, and DNA methylation and all that. So in talking with a lot of these advanced diagnostic labs, which, by the way, is another significant use case, and I'll bring that up in a sec, they would love to be able to send the epigenetic reports to us, and for us eventually to be able to send back the identified, the demographics and the contextual data of this patient surrounding those epigenetic results, because then it gives them context to continue optimizing their models and continue evolving and improving. Now, again, there's complications with data privacy and how that's going to be managed, but that's a great example of how you can use contextual data to augment other data components and make that stronger and better. So that's just another example. And where I was going to go with advanced diagnostics is there's so many use cases that come out of this. For instance, in talking to a lot of these folks, they spend a lot of resources, and they have a lot of professionals, practitioners, providers, physicians that are there to help their professional services clients, like other clinics, interpret these reports. right? So if you get a genetic test or a DNA methylation, who knows this? 70 pages, how do you interpret it? And so they're helping the providers walk through these, help them interpret them, and that's a lot of resource. So imagine being able to have a system that can really ingest these reports and help translate them into actionable insights for the provider. And even more importantly, is not only siloed, because today a lot of these diagnostics labs are creating their own reports and their own actionable insights and their own recommendations based just on the genetics, or just based on the lab tests, or just based on this or that. And that's where we see the emergence of all these direct-to-consumer companies like Function Health and Superpower. They're doing these 500 biomarkers and cancer pre-screening, right, and giving you actionable insights. But again, that's in isolation, it's siloed to those 500 biomarkers. They don't know your lifestyle. They don't know what you eat or what you don't eat. They don't have at preview to maybe other inputs, and this is where it becomes really interesting, because the amount of data and the emergence of all these advanced diagnostics. I think in the first hour we were talking about how one of the reasons we really like this personalized medicine space is because these providers are going way beyond in looking at data that transcend what traditional allopaths are looking at, right? Not only are they looking at blood tests, but they're looking at hormones, GI maps, breath analysis for metabolic function, epigenetics, genetics. I mean, you name it, there's tons of different data points. And so being able to really capture all that, connect the dots, is not a task for a human brain.
The terminology around all this, because I know a person can carry a certain diagnosis, but then what's that next level? You say they have a tendency for, or what do you even call this if they have biomarkers for X or Y?
Well,
it just seems like there's a whole need to be able to talk about that in a certain way.
Yeah, and that's an excellent point, because a lot of folks think AI is making decisions for providers. I mean, in my opinion, there's a couple of things that are always going to require human intervention, and by human intervention I mean empathy. Right? Love and medicine. I think in order to have a relationship with another human being and have that empathy, it needs to be a person to person. Some people may disagree with me. And also from a medicine perspective, I think it's the same thing. You want a doctor that is going to have empathy. You want a human being. Now, that doesn't mean that in the future, 70-80% of the use cases in medicine, especially those annual checkups or routine tests, cannot be done automatically. But when there are symptoms, when there does need to be treated, you do need a human, right? And that you need their judgment, and they need to be able to explore all the possibilities. So to your point, and it's a very good one, the AI is not telling you what it is. They're telling you all the possible options that you should consider and why you should consider them. And then you can communicate with the AI and present more information or ask questions to help you qualify in the context of the patient's data. So it becomes almost like a brainstorming session. It's almost like if you had Socrates, the first doctor, and he knew everything about everything, and he knew everything about this patient, and you could have him next to you 24/7, and you could say, hey, patient A, what do you think is going on here? What are the possible diagnoses? And he could say, listen, I don't know for sure, but it sounds like it could be one of these 8-9 things. Let's go through them. By the way, let me ask you a few questions about it so I can help you qualify which one to look at first. Right? It's not a deterministic approach. It's not going to tell you it's this, do that. It's going to tell you these are the things, and then the exchange of ideas, the conversation starts. And so that's really the way to think about the augmentation side of this. AI also facilitates on the automation when it's a task that's routine, but we're not talking about that right now. We're talking about clinical decision making that does require that exchange, and it does require human judgment.
David, can you walk me and Jeff and the listeners through what do you envision a typical user, and when we say user, we mean the nurse practitioner, physician, et cetera. Walk me through that patient encounter from start to finish on what you think that looks like with WellPro.
Well, the truth is it looks exactly the same as it does today without all the heartache.
That sounds great.
And so if we're going to walk through this, you come in the morning, you look at your schedule, you see all the patients. Some people do the pre-visit or the pre-charting the night before, 2 days before, that morning while they're walking into the meeting. Here you can immediately see, you can hover over it, it'll give you labs, it'll give you the overview, you can click on it, see a summary, there's a chat, voice or text, you can ask any follow-up questions. It'll just give you the essence of what you need to know to go in. And if you have any follow-up questions, you can verbally or through text communicate. Now, of course, the verbal piece Where are you going to communicate? If it's in a hallway, there's HIPAA, right? So there's considerations, but essentially you don't have to go in and review every document and review every chart and go back to the last chart and look at that. That's a lot of time lost, right? And this is the way I kind of explained it to my wife initially. What would you prefer? To write an essay from scratch or get one that was 97% there and just look at it, edit it, tweak it, and send it off, right? And so that's an augmentation. And even better is if you don't like it, you could just explain why you don't like it and have the system redo it for you and direct it, right? You're saving a lot of time. It's more eloquent. It's more articulate. It's more precise. And so every step of the way, it's the same. So what you would expect in WellPro is to see significantly less clicks and menus, because what used to take you 3 or 4 or 5, 6, 7 different clicks now it takes you maybe 1 or 2. Where it was buried deep 3, 4, 5 levels down, now you could just through voice or text get that information right away. You can query things that before you were not able to query. You would have to look at 4 or 5 documents in order to come to a conclusion. Now you just ask a question and the model is going to develop that response based on all that information for you. As you can see, menus and clicking is not going away, which actually is a great point, because in theory, we could have a system that was almost like Jarvis, Iron Man. But it's not normal. You're not used to that as a provider. So we need to leverage what's normalized, even if it's on the on pushing the envelope on that. We're used to seeing what's going on, clicking on stuff, moving through a visual workflow, right? I think eventually over time, call it 5, 7, 8, 10, 15 years from now, we're going to have Alexa with the screen. Everything is, that's the natural way we communicate is through language. And so when folks really trust the models, when they trust the outputs, imagine just being able to talk and having a screen where you can reference things, but everything is just a verbal conversation, a verbal commands, verbal follow-up, do this, do that, and make this decision, present this information, right? And so that's part of the evolution. We're making sure, and that's why we have everything modularized. So throughout time, the way we present the user interface and the user experience is going to change over the next 10 years. And we're preparing for that already. So whereas today, all three of us are going to go into WellPro. We're going to see the same menus, the same system. In a few years, we're now starting to see the convergence towards generative UI.
What is that?
Where, depending on who you are, it's starting, right? There's some Python development behind that. You can start seeing some prototypes, but there's still a ways to go. Is Jeff Cole, if you go into the system, you're going to see different menus, and depending on who you're seeing and what patient, what they need, the system is going to be there for you. It's going to react and be proactive and prevent for you. Whereas Jeff Brown, the interface is going to be different for you and what you're trying to achieve, right? And then eventually we're going to be in a situation where there's going to be less and less menus and clicks and more verbal communication and more supporting screen. I mean, we may have glasses where instead of having a traditional screen, you can see it on your eyeglass frame. That's over time. But even though the technology is there today to accomplish this, can you imagine any provider wanting to go about this? It just feels not normal. I mean, our muscle memories have been trained to do things in a certain way. It can't change overnight. So that's another incredible point, is you need to bring something that's going to make it easier, faster, but it can't be so advanced that it doesn't feel natural and it just feels uncomfortable. What's normal will evolve over time, and we have to evolve with it so that our platform never becomes obsolete either.
Yeah. Jeff Brown, I don't know if you know this, but I started an EMR company in 2003.
Yeah, I remember.
And
you were ahead of your time.
Was involved from the very beginning, and it was awesome. It was for orthopedics. It was office efficiency. We ran the company for 15 years, well past the time when we decided we were not going to go through the CCHIT certification because it was going to force us to put all this crap into the program that really wasn't relevant and was going to slow us down. In the end, that kind of is what killed us. But it's just interesting to see just what's happened over time, because we built ours Microsoft backbone really before .NET came out, but our programmers were basically kind of using the same technique really at the very beginning of, I don't think the iPad was out yet, but
no way.
Transitioning to an Apple platform, we never did. Anyway.
You raised some interesting. It's a good time to be in this sector, because you talked about certification, and that's really interesting point, because when you think of why EHRs were created, it was not to make clinicians' life easier. It was to manage all the compliance requirements of billing, right? I mean, that's a lot of the reason why it was built. And certification is all about compliance. And so today there are headless EHRs out there that have modules that take care of a lot of this stuff. That doesn't mean we have to go and build every single piece of that from scratch. So the stuff that's not core, that's not going to impact the experience of the user, that just needs to be there, it needs to be put in place, we can implement other modules to accelerate our go-to-market so that we can have an EHR, ultimately, as I call it, it's not EHR, it's an IHR, Intelligent Health Records, which is the AI native, the next generation version of the EHR, right? Which is ultimately what we're working on building. I could definitely understand why that would have been a showstopper, because it's a lot.
Yeah. Well, we got sold that the EMR was going to help us clinically for sure. I'll tell you one problem, and you spoke about it earlier, probably not something WellPro is going to fix, but you touched on it because you're talking about porting your own data, taking it with you, etc. I even tweeted this to Elon Musk. He had requested all the physicians, tweet inefficiencies you see in healthcare, and let's see what we can do there. And I said, well, one easy thing would be, I cannot tell you, well, you probably know, but how many times does someone get a CT scan at hospital system X in town because the other one's at hospital system Y? I think there's so many redundant things, lab tests, and the systems don't talk to one another, right? Should there not be some standardized system where at least, even if you don't own the data, you can access the data, right?
Well, that's I think the point that Jeff Cole was making before was being certified is you have to put in place either FHIR, HL7, or these interoperable capabilities so you can talk to each other. Yes, that's not something we're working on solving the interoperability between systems. What we're making sure is that our platform is interoperable and can communicate with other systems. But that's a long-standing problem. In fact, I would say because the incumbents are so enrooted today, there's still plenty of work that will be done and needs to be done to advance interoperability, even in the age of AI, because these systems are not going to go away overnight, especially for healthcare systems. They're not going to transition away from Epic anytime soon, right? And in fact, Epic is one of those that has been doing a lot of work, and who knows? I mean, I would not, if I was a betting man, I would put my money on them because they're doing a lot of things right, but it maybe not necessarily the case for most of them. But yes, interoperability is a huge challenge, and it's going to take a lot of time and a lot of work to continue doing that. And there may be some solutions that can help facilitate that in translating structured or unstructured data and converting it into a common protocol that can be shared. I'm sure there's going to be plenty of solutions out there that are going to work on that bridge.
Talk about when you expect your platform to be available for the wellness segment of the market, and then also talk about what your deck showed as phase 2 and phase 3 as far as clients in the future.
So, and I would even say maybe, wellness is a good way of thinking of it, but our co-development partners now are, at least a couple of them, are actually they were originally traditional allopaths that went into functional medicine. So they practice medicine many of the same ways, but with significantly more data. They spend a lot more time with their patients. They go into the root cause. It's just a more extensive, holistic approach to medicine. So it looks significantly more like a primary care practice would be with all these value-added services, but it incorporates that wellness piece. And we're working, the beta is going to be released in mid-August, and we're scheduled for our first commercial release at the end of the year. So, and beyond that, we have a significant amount of roadmap to work. I mean, we probably have 4 or 5 years worth of work to do. What I'm very focused on is how do we scale and accelerate efficiently so that we can condense those 5 years into 2 years or into a year and a half. And listen, we're eating our own dog food. I mean, as an AI first company, we use a lot of AI tools ourselves to accelerate development. For example, all of the developers work with Cursor, which helps them with coding faster and more efficiently. With our QA, our quality assurance, we're employing software engineers that are writing code to automate, as opposed to just doing the manual checks. So we're implementing AI ourselves wherever we can. In fact, in my deck, I don't know if you got to the end of it, and that deck is not the final deck because we're still a week or two from starting our capital raise. And I sent you a long deck that we're going to be streamlining. But in the next to last slide, we have an AI investor concierge. You can call the number and you can ask any question you want about the investment. And go ahead and try it out. I think you're going to be surprised. It may not be 100% perfect, even though I think you will think it, because we've trained the model with enough nuance and detail where it does a pretty good job. But it's pretty impressive. So everywhere we can, we're employing, and we call it eating our own dog food. But it's a marvel.
David, let's talk about your revenue model since we're talking about finances, and then let's talk about that capital raise, valuations, minimums, etc.
Yeah, so on the business model today, again, because we're so early, we're still in the build process, we still have a lot to go. To me, one of the most important things initially was to make sure we had authentic demand. And authentic demand is when you have a customer willing to pay for something before it's fully built. And the reason I'm mentioning this is because these co-development partners are working hand in hand with us to design and test and provide feedback through every step of the way. And it's proving to be probably the most important catalyst for our success is in that approach, right? And so, but the reason I'm mentioning that is that in order to get them to pay a year in advance, we had to have a pricing model. And so most people are used to the traditional SaaS model, software as a service, where you pay a per user and you pay a platform fee, or a licensing model like NetSuite, or where you pay a platform fee in a fee per user, a licensing fee per user. That's our current really preliminary pricing approach, but the key is a transformation to a more practical business model for the AI world. And I'll explain what I mean by that, but we are going to be migrating to a value-based pricing model where it's cost per, or an investment per agent, for example. So if one of our agents is replacing 3 of your people, there's significant value there, right? If we're saving you 15, 20 hours a week versus 80 or 90 hours a week, there's significant value there. And so it's not going to be a linear pricing model. It'll be a value-based model. And I'll explain a few reasons. Not only because that's probably a better way for us to monetize on value, right? But also because the way AI platforms are built are very different from a gross margins perspective than the way traditional SaaS was built. We're migrating more to a service as a software model as opposed to software as a service. And what I mean by that is with agents, today there's a lot of variability between one user and another. If you're onboarding a patient that has 2 documents, the cost of ingesting and processing that data is significantly different if you have a patient coming in that has 100 documents or hundreds of pages, because you're paying for the compute, you're paying for the usage of LLMs, of the models. And so the traditional pricing model does not work well in this context. And so I don't have that very well defined yet. That's something we're thinking about and working through. Ultimately, we need to make sure that it's a model that is easy to understand for our users. Pay us X amount per every document you upload, or for the amount of tokens or characters that are processed. I mean, who understands that? It makes your head spin. And so that's not, but if we can present pricing based on demonstrated ROI and demonstrated value, that's the model that we're going to be pursuing.
That makes sense. What about your capital raise?
So we're total, it's 4.5. We're going to raise 2.5 first, which is the deck that I've sent. We already have 500.
2.4.
We have a pretty good idea of where the market is, and more than likely it's being set right now we have already 500 committed that are coming from our angel investor who's investing again, and a couple of our co-development partners are coming in now with actual investment cash. They see where this is going and they're investing. So, but that's a conversation as far as valuation that happy to have. We're not going after the venture capital route. And we talked about all the reasons why that's not the right model for us. We're building a generational company. We're building this with a long-term outlook. And, we want mostly, we're looking at accredited private investors that are advocates for health and wellness. There's a few docs, of course, that are involved, but some of the investors that we're talking to are already users of functional medicine. They understand the value and the opportunity, and they're all over this. So we want to make sure that we're aligned. There's value to the capital we're raising, but also that we're aligned in terms of mission, vision, and horizon with our potential investors. We're happy to have the conversation with anybody that's interested.
The clients you said were willing to wait for the product. Did they literally pay for the product and wait, or did they put money in as equity?
Well, no, they paid for the product 1 year in advance. For this initial round, it's $25,000 they each put in. It's not an investment in the company. It's services. It goes towards our ARR, even though we don't have a commercially launched product yet. And 2 of those co-development partners are going to be investing in this round. And
Okay.
that's part of the 500,000 that I say is committed. And to me, that's the best indications. And these folks work with us on a weekly basis. I mean, we meet with them multiple times per week. In fact, one of them promoted their top mid-level to medical director, and he spends 2 days a week on this project. I will say one of the hardest things when we were first starting to try to, it was not called co-development partners initially. And it made me, you know what, I'll touch on that for a second because I think this is very important. And I wouldn't feel as good as I do today if we didn't have this, because it's very dangerous to build a product speculatively, especially if you're building a very broad product with a lot of surface area, to build it speculatively and then see if the market, how they react. And you need somebody that's working with you step by step across the whole way, testing things as you go, giving you feedback. And so when I first started talking to providers about potentially, or clinics about being a pilot, everybody wanted to do it. Everybody wanted to do it until we needed to have meetings, and they needed to show up to the meetings consistently. And when they needed to come up with sample data, they did it at a timely basis. And that's when we started running into a lot of issues, because folks were just, oh, I don't have time, let's move it to next week. And I haven't put this together for you yet, or I haven't had time. And that's probably the biggest challenge, is how do you get people with time? So interestingly, the 3 clinical groups that we have all have COOs, and those COOs put a lot of emphasis in making sure they're engaging their teams and they're allocating the time to this. They're heavily committed. And that's probably the hardest thing to find when you're building a broad platform like ours, is committed users that are going to be willing to spend, 10, 15 hours a week working with you on this stuff.
Well, it makes sense that they're going to put some capital in, because I would be surprised if they were doing all that work.
Right.
I'd want to own part of what I build,
Right.
Absolutely.
Yeah. Well, David, we strive to have guests on here that check mark my three boxes. That's help patients, help physicians do their jobs to take care of those patients, and at least give us the opportunity to enrich ourselves financially. You absolutely check mark all those boxes very well. We've been talking, at least recording now, well over an hour. This is probably a good point in the podcast where I ask you if there's anything that we didn't talk about that we should cover briefly.
Yeah, there's probably about 10 or 15 more hours worth of
Right, I know.
conversation that we haven't touched on yet.
Yeah.
But if there's anything you guys want to cover that I haven't covered, but this is a bottomless or an endless conversation. There's a lot of nuance to it. There's so much to be discussed. And just from an ideation and idea experiment perspective, there's just a lot of fascinating things to think about and talk through.
We didn't, we talked about, this was offline, but this whole DeepSeek thing, we didn't record that conversation. And just from a philosophical standpoint, I'd like your take on that.
As I mentioned initially, I'm not really privy to much more than we all are with some of the articles coming out where DeepSeek is, totally devastating these large investments, and they're able to do all these things at a much significantly lower cost. And there's maybe some veracity challenges to some of these statements. Let me bring it more to a high level. And this is where we're seeing a big shift. Is in the last few years, a lot of the capital, the big capital with these foundational models, has been in training the model. That takes a lot of compute, that takes a lot of time, that takes a lot of people, that takes significant cost. Where we're starting to see a shift is much smaller groups with significantly less funding are starting to take getting access to some of these open source models and are focusing on inference as opposed to training it, and becoming a lot more productive with better results using inference mechanisms. So we can start getting into all this, but the good news is now there are new startups with 2-3 people that are going after these, how do we optimize these models? How do we optimize these models for very specific verticals? And so that's going to continue. So the good news for us is that as we continue building this out, the models are just going to get better and better and better exponentially. And that's not something we need to be working on. There's plenty of people working on it. We're going to be connected to those models. And so DeepSeek is no different. Now, we happen to be in the medical field, so there's the criteria for accuracy and quality of models we're using has to be clinical grade, and has to, so it's a little bit different than using these generic models. We happen to be associated with Google, and we're using a lot of different models outside of Google, but Google's doing a great job with their Gemini model, and they're doing some really sophisticated things that we're super excited about, and that's one of the reasons we moved from AWS to Google Cloud. They're putting a lot of effort there, and so there's just a lot of exciting stuff. It's hard to even predict what things are going to look like in 2-3 years.
It is. And just if you humor me, just one more maybe philosophical question, because I mean, we were all alive when people paid to send an email, and we were alive when the internet was born. We were alive when the GUI came out and all of these things. And now the LLM is our GUI. But my point that I'm making, and I want you to comment on this, these things all became commoditized, and ultimately the internet became free, if you will. You pay for the broadband access or whatever, but I can be on Google all day long and it doesn't cost me anything. And now I can be on Grok all day. It doesn't cost me anything except the electricity. Are these systems going to be so sophisticated that people will continue to pay for it? Is there some threat to commoditization that would be a threat to something like WellPro or all of these other things that we're discussing?
Very good question. And that's one of the reasons we're taking the long route. So when you look at point solutions, that's happening now with AI Scribe, which AI Scribe is simply listening to the encounter, transcribing.
Everybody's got a scribe. That's what I'm saying.
There's 800 plus of these folks in the last year and a half. And it's become common. There are now players that are offering it for free. The prices have gone down significantly. Mm-hmm. So it's a race to the bottom. But it's very different when you own the full experience. And that's not something you can commoditize. Now, costs are going to get significantly lower for us as far as accessing models. It'll get better and lower. Just like the 80-inch TV screen used to cost $10,000 5 years ago. Now you can buy them for $1,200 at Costco, right? I mean, for these huge screens, it's unbelievable. That's one of the advantages over time that's going to happen with the foundational technology. But the day-to-day user experience, whoever owns that is going to be really able to control. And so that's where it becomes a little muddy, because these legacy EHRs have the underlying infrastructure. The co-pilots have some of the experience, but really, in order to create a significant moat, you need to own the full experience. And so that's one of the reasons, too, that we're building this from the ground up. And we feel this is going to be the long-term competitive advantage to what we're doing. I mean, if we were building something smaller, more specific, we may be able to go to market quicker, generate revenue quicker, faster, right? But I think we're going to start seeing some serious limitations in the next few years as AI progresses exponentially quick, sitting on top of old legacy systems. There's going to be a lot of bottlenecks. So it won't be able to fully optimize. I'm not saying EHRs are going to go away, especially not the big ones. They're way too embedded, but it is a consideration. And it will be interesting to see what happens over the next 10, 15 years with all these large traditional EHRs. And whenever anybody says they're too enrooted, they're too big, we've heard that story before multiple times.
I feel like if AI pricing comes down, like you may end up, in theory, spending as much money because you're going to be asking more of it. Does that make sense?
It's good reasoning. I will say that it's not only that it becomes cheaper, but it also becomes significantly more cost effective. And it's hard to understand that. I mean, the reason I think I can see that happening is because even the methods. So for instance, when you have all these documents that you're utilizing in order to feed the prompt, it's called RAG, retrieval augmentation generation. The methodologies for these, the methods, have evolved almost every day for the last year, right? It's getting better and better, more and more efficient. So I think costs are going to go down. We're going to use more, but also the usage is going to be significantly more efficient. The way we retrieve data, the way we use data, the way we store data. And so it's the curve is more cost effective, faster, better, more efficient. And that will just equal significantly more potency to what we can do. Much less latency. Latency is just the time that it takes. So if you try out the AI investor concierge, it's like having a conversation with a real person, but there may be sometimes, an overlap and it may just wait half a second. We're going to get to the point very soon. I mean, just the difference between today and when we were running these demo models 6 months ago is night and day. I think next year, you're going to be talking to these inbound assistants and feel you're talking to a human. I mean, that's how it actually challenges it. I was listening to one of the recordings because we did some AI inbound assistance for some of these co-development partners initially to just blow them away, right? And essentially, we trained the model and everything on the clinic. So you could call, ask any question about the product, service, price, location, anything. They would explain it. You could share your wellness objectives, your symptoms, and it would recommend products and services, and then it would guide you to scheduling an appointment. And so I was listening to some of these recordings, and one of the guys spent like 20 minutes, which, by the way, back then it was like a minute, $1 a minute. Now it's down to 28 cents a minute, so it's getting significantly cheaper. But he, this was a female AI assistant, sounded very nice, and he was, I think, trying to test out saying, listen, hey, would you like to go out for coffee with me? And, just hitting on and it was really interesting to see how articulate and how tasteful and graceful the AI assistant was able to manage that whole situation. I mean, it was just, for me, it was like, wow, this is unbelievable, right? And we're the ones that program it. So oftentimes we're even surprised at the marvels of what we're developing and how it's manifesting itself. It's truly remarkable.
Yeah. I can only fathom what the next 5 years looks like, especially considering what the iPhone came out probably now 15 years ago, maybe. I'm sure it's not much different than that. David, I think we'll leave it here. I want to really thank you for an incredible 2+ hours of stimulating conversation. I know I could personally do this all day, and next time you're in Memphis, you need to look us up. You guys listening out there, thanks for joining us on the Merge Medical Podcast. I'm your host, Dr. Jeff Brown, joined by my co-host, Dr. Jeff Cole. Thanks, everybody. Peace out.